understanding like what's uncomfortable, what's not uncomfortable. Are they tachycardic? Are they over-breathing the vent? Like, is their respiratory rate 30? Like, they probably need some pain control. That makes people cough and buck. So that's why a lot of times you have a patient who's comfortable in the ICU and you turn them and the breathing tube goes in just like an extra half a centimeter and then they're like this. Pain control and sedation, not the same thing.
They're not the same thing.
Not the same thing. This is such a huge point of confusion for people in critical care. I think because primarily a lot of our pain control medications have sedating effects. So oftentimes we confuse sleepiness with comfort, and they're really not the same thing. So today we're going to dive into why you need adequate pain control for your ICU patient, how it's different than sedation, what the different drips are and like how they work. And we're not going to get super deep into it because honestly, that's like an hour-long lecture in and of itself. But we'll go over the overview of why it's important to understand the difference between making your patient sleepy and keeping them actually physically comfortable.
Sounds good. As we dive into it, my name's Anna. I am a first-year student registered nurse anesthetist, and I have been a travel nurse the last 2.5 years.
I'm Chrissy. I'm a nurse anesthetist, and I've been a CRNA for the last 5.5 years. One of the biggest things that shocked me, honestly, in CRNA school was like understanding this at a way deeper level. And I remember being like, oh my God, if only I do this sooner. Oh. So today you guys are going to get all of the knowledge that I never had and hopefully feel a lot more empowered to care for your patient and keep them comfortable.
Yep. So there is an in-depth lecture and it's in the Confident Care Academy membership. So we're going to have lectures on opiates like fentanyl, and we'll have a propofol lecture, a Versed, we'll have Precedex, all of that.
Those will all get those own separate mini lectures.
They all get their own separate mini
and
lectures.
And there also will be a way deeper dive analgesia versus sedation versus paralysis lecture, which I shouldn't even have to add that, but that's another rant for another day.
Paralysis is also not the same as sedation.
I'm going to rant about that in another episode because I don't want my blood to boil. But
we'll circle back to that. But all of those in-depth lectures, if you're looking for a pharmacology review, will be in the membership. But today we're just doing kind of a general broad topic talking about the difference between the two.
Yeah.
So what do you think the first thing is like that people often get wrong on like their assessment?
The most important thing to understand is that your ICU patient is probably having pain.
Yeah.
So this is, of course, going to be very situation dependent, very patient specific. Their age comes into play. If they were on home opioids or had a chronic pain diagnosis before they came in, did they just have a major surgery? Have they been here for 3 months and they're really not having pain anymore? They're just deconditioned? Are they super swollen all over? Like all of these different things contribute to a patient's pain. It's extremely important to have good pain control in the ICU because poor pain control leads to poor outcomes. I'll link an article here that you guys can read more about it, but essentially poor pain control in the ICU can lead to PTSD, it could lead to delayed discharges, it can lead to all of these different like increased stress responses in the body that cause your patient to be sicker. So please, please, please understand that pain control is crucial in the critically ill patient.
Even for a patient who is not at the very critically ill intubated moment, pain control is really important for like fresh post-op patients so that they can
get out of bed.
in enough pain, but not enough pain that they're not going to be able to get out of bed.
Yeah, you want them to be able to get out of bed. You want them to be able to take deep breaths.
Yes.
You want them to be able to do the things they need to do to recover. We also don't want them snowed and not breathing. So there is a gentle balance there.
Which is why you need to know the mechanism of action and how things present differently. And that's why we're talking about all of this today.
And we'll get into that later in this video. It's also really important to understand that sleepiness doesn't equal pain control. So although our opioids, medications like fentanyl and Dilaudid and morphine, do have the side effect of causing sleepiness, they do have sedative effects, that doesn't mean that sedation works the same way in reverse. So your midazolam, your propofol infusion, those things, just because your patient's sleepy, it does not mean it's controlling the pain pathways or blunting the pain response. If you continue to crank up a propofol drip high enough, eventually you can knock anybody out and make them asleep. But the body might still be mounting a response to pain. You can mask those effects, but you're not necessarily controlling it. Now, in the ICU, we have these limits. Usually, most ICUs don't allow nurses to run the propofol over 80 mics per kilo per minute, I think is what our rule was. Of course, I'm sure the policy is going to be different everywhere you go. And this is on an intubated, like ventilated patient typically. I think it'd be kind of crazy to run propofol as a non-intubated patient, but that's okay. That's something we do in the OR. That's like a completely different thing. You know, a lot of times people will see a patient who's coughing and bucking the vent, and they're tachycardic and they're hypertensive, and these are all cues that your patient's in pain. And then they say, oh, go up on the sedation. That agitation and sedation is like not, again, the same thing. Really, you could probably just give your patient like 25 mics of fentanyl, 25 mics of fentanyl, 25 mics of fentanyl, get them nice and comfortable, and then leave the propofol drip where it is, or maybe even decrease it.
Again, especially for the fresh post-op patient who has massive incisions, who has a lot of swelling, inflammation, and a breathing tube, they're uncomfortable.
Those things are uncomfortable.
That's not a comfortable situation.
Having good pain control is also going to help you to wean down the sedation faster, get them compliant with the ventilator faster, get them into a spontaneous mode, and get your patient extubated sooner. Like talking about like a fresh post-op patient, for example. Mm-hmm. So these things are really, really crucial to understand. We can talk a little bit about the different pathways. Like, again, opioids are primarily working on opioid receptors. And there's different subtypes of receptor, delta, kappa, mu.
Right.
And there's like even more subtypes after that of like things that are related to that pain system, which again, we'll get into in the CCA lectures. But essentially what's happening there is that these receptors exist in our brain and spinal cord. And when an opioid binds it, it's decreasing the amount that those neurons transmit the pain signals. It's making the pain signals transmit less often because it's hyperpolarizing the cell, meaning making it less likely to be able to conduct an action potential. We get into that in the CCA membership. We have a whole conduction lecture all about action potentials.
Come join us for more.
We'll review it again in this lecture in depth, but basically you're less likely to transmit pain signals. They do have side effects of sleepiness. They can have side effects like itching and nausea, depending on like the type of opioid that you're using. They can have other side effects like, I don't know, whatever. Sleepiness, itching, nausea, whatever. Respiratory depression, obviously. That's how people overdose, right? It's like their drive to breathe goes away and they're not breathing enough, and then they hypoventilate, and then their carbon dioxide levels rise and they become acidotic, and then that's how people, unfortunately pass away. When we have sedation drugs, they're working on a completely different pathway.
Totally different pathways.
They're primarily working on GABA receptors. I remember when I was first learning about the GABA receptor, it was my first degree, it was my psychology degree and my psychopharmacology course. And I remember the way that I memorized GABA was like, go to bed. That was like the receptor that like helps regulate sleep. Like when you activate the GABA receptor, when you turn it on, it makes you sleepy. Now, most of our sedation drugs are not direct agonists. They're not directly turning on the GABA receptor. They're like basically helping modulate it to make it more likely to bind to agonists that already float around. But the bottom line is, the short version for the podcast is that when we have medications on board, like midazolam, like Ativan, like propofol, they all work slightly different, again, from each other. They all have their own unique properties, but sedation medications as a category help make the GABA receptor more active. That also hyperpolarizes the cells through the chloride channels, and essentially it makes it less likely to conduct activity in the brain as well. But a different part of the brain than pain control. It's the sleepy center. It's making you more sleepy. So again, if you're sleepy enough, you can mask signs and symptoms of pain, but it doesn't mean your body's still not having a stress response to pain.
Yep. And this immediately, you'll be thinking, has a couple of nursing implications, right? So you've likely worked somewhere or floated somewhere where a patient was a rapid sequence intubation, and then you are instructed to hang a propofol drip. Propofol is not an analgesic. So you are not controlling this patient's pain by sedating them. Is that appropriate? No, it's not. And just because potentially your APP team or your physician team isn't immediately primarily concerned with analgesia in addition to sedation, you should learn this and be aware and advocate for your patient.
Okay, I would like to clarify a point here before you guys misunderstand what Anna's saying.
Yes.
After an RSI, you should 100% hang a propofol drip. In fact, have that ready to go before the RSI happens 100% of the time, because most of the time when we're intubating critically ill patients, we're using a paralytic called rocuronium, and that one-time RSI dose of rocuronium is going to keep your patient paralyzed for 45 minutes.
It's a long
so
time.
Please keep them asleep with propofol. We don't want them to be aware of what's going on in any way, shape, or form. What Anna is saying is that if this is a patient who is also likely having pain, then please, in addition, get orders for pain control on top of that, right? like an additional PRN for
That's what I'm saying. I'm not saying don't hang a propofol drip.
Yeah.
Get your propofol ready before you even go into the room. Like have it hanging and ready to hook up, but also get pain control in addition to your propofol drip.
And it depends on why your patient got intubated, right? If this is like a patient who got intubated for respiratory distress and they don't necessarily have like a fresh incision and they're not necessarily like super swollen all over, like maybe they just need some sedation and then like we'll do some ventilator optimization and like maybe we don't need to be giving them like a ton of pain control. Like it really just depends on what their pathology is, but you have to understand your patient population. Like, is this patient likely having pain? Yes or no? A breathing tube in and of itself isn't necessarily super painful. It can, if it hits your carina, that's where your right and left main stem bronchi branch off of your trachea, that's very stimulating. That makes people cough and buck. So that's why a lot of times you have a patient who's comfortable in the ICU and you turn them and the breathing tube goes in just like an extra half a centimeter and then they're like this. It's because the tube's hitting the carina. That's like very uncomfortable. It stimulates your cough reflex. But the tube itself sitting there is not necessarily like super painful in and of itself. It's like a little uncomfortable, and getting ventilated with positive pressure ventilation, like having a ventilator blow air in and out of you, like it's a little uncomfortable. So like some pain control is necessary, but they don't necessarily need the same amount of pain control as like a fresh liver patient or like a fresh open heart cardiac surgery patient. So like understanding like what's uncomfortable, what's not uncomfortable. Are they tachycardic? Are they over breathing the vent? Like, is their respiratory rate 30? Like, they probably need some pain control, right?
They're probably uncomfortable. Right.
Yeah.
Yeah. So even for a patient who is not, pain is probably not the underlying one of the contributing factors here. So like you're not, at this point, we're not talking about a fresh surgical patient or somebody or a trauma patient. Like, please treat your trauma patient's pain. Please. Please. But even for a patient who is a RSI for whatever else reason, you should still advocate for PRN pain orders.
You should always have the option available.
You should always advocate for PRN pain orders so that if a patient does become symptomatically uncomfortable, tachycardic, tachypnic, looks like they're in pain, biting down on the tube, like you want to have a PRN order, even if a patient is not necessarily like, oh, this patient probably needs a fentanyl drip. Like a trauma patient probably needs like propofol and like a low dose fentanyl as well. Like it's really uncomfortable. All of their bones are broken. Like that's
they probably do need in fact a lot of different things for pain at that time. Yeah.
Right. So again, like have PRN orders for any like critically ill patients so that you can like use the tools in your toolbox, but then also just understanding that propofol in and of itself, just because a patient is quiet and like sleepy, if they're on like a like 50 of propofol, they might still be experiencing pain. And then use your assessment skills to do that. That's all that we're like saying here is
exactly
treat your patient's pain. Think about, is this patient in pain? And if they had their chest cut open and then sewed back together, it's probably uncomfortable.
It doesn't feel great.
It's probably not comfy.
Things that are painful that like sometimes like you just like learn like what's painful, what's not painful. Big abdominal incisions, very painful. Anytime that you're cutting through a lot of muscle, very painful. So what's interesting in cardiac surgery is like young men with like big like pectoral muscles or people who just like have more soft tissue there because of their body habitus, like they're gonna have a lot more pain with sternotomy than that like skinny little old lady who's like 90 years old and 90 pounds. Like skin incisions like aren't that painful, and actually like cutting the sternum itself, like there's like some pain, but like the muscle cutting is what really hurts people. So big belly incisions, really painful. Broken bones, really painful. Interestingly enough, like even like craniotomies, like it's mostly skin. There's not a lot of, well, believe it or not, it's actually less painful than, like if anyone's had a cranie, like you can correct me if I'm wrong, but what we've noticed in the OR and like with their post-op pain requirements, it's a lot less than like an open belly patient. Because you would think cutting your head open,
muscle.
There's not a lot of muscle tissue there. So it's really like scalp and then skull. And what tends to be painful for those patients are like the post-op swelling on the brain.
Yeah.
Like that obviously is super uncomfortable, like that headache. But the incision itself is not what's like driving a huge pain response, like for an abdominal surgery, or like if someone like has like a broken femur, like that's extremely uncomfortable.
Which circles back to what you were saying a little bit earlier. Patients who have like massive amounts of third spacing and they're very swollen, that's also painful for patients. It's really painful to have all of this swelling, especially if that's coupled with incisions and all of this stuff. So be aware of that as well. That's also very uncomfortable.
Yeah. If your patient is swollen like a water balloon, like that hurts.
Yeah.
That does not feel good. Again, like the breathing tube, if your patient keeps coughing and bucking on the tube, that's another thing is like look at the x-ray or like ask somebody else to look at the x-ray. Like maybe ET tube is in too deep. Like if it's tickling the carina and
You're going to be coughing.
they could just withdraw it like a centimeter. That's something I noticed in the ICU, and we all laugh about in anesthesia. All the patients' tubes are like at 26. They're all about to right main stem at any given time. 26 centimeters at the teeth is so deep. That's so deep. Unless
22 to 24 usually.
Unless you're like 7 feet tall, like that's way too deep. So
which, and then that circles to another podcast episode we're going to do about respiratory devices and then assessment, right?
Yeah.
So like checking your ET tube placement should be a part of your assessment at the beginning of the shift, especially if you're doing a lot of mobility, moving your patients around a lot. The tube can get a little bit dislodged, so make sure that it's like staying in the same place. That's another assessment piece. Do you want to talk a little bit about Precedex?
All right, Precedex is so this is where that like weird intersection of sedation and analgesia come in. Like we have a very hard line between medications like midazolam and fentanyl. Like this is the pathway this works on, this is the pathway that works on, and this one is anxiety and sedation, and this one is pain control, but it might make you sleepy. Like, okay, fine, that's easy to understand.
Right.
We get into drugs that have effects on completely different receptor pathways, or maybe sometimes they work on both receptors, and now things like get a little bit more blurred. Dexmedetomidine or Precedex works on the alpha 2 receptors in the brain. Like what? Like a whole different process here. So when you are working on that receptor, it also causes primarily that anxiety relieving effect. Anxiolytic.
Anti-anxiolytic, yeah.
And we're also making your patient sleepier. It also does have some analgesic properties, some pain control properties, but it's not a strong or potent analgesic. So it works really well in conjunction with other pain medications to make the pain control better.
Right.
So if you run dexmedetomidine with a fentanyl infusion, you can have lower doses of both. You'll need less fentanyl because the dex is helping with the anti-anxiolytic, and it also does have some of those analgesic properties. And then again, because you're getting some sedation from the fentanyl and some pain control from fentanyl, you'll need less dexmedetomidine. So if you use them together, they make each other more potent, more effective, and that's called synergy. They have synergetic effects with each other. So they both make each other stronger. Instead of 1 + 1 = 2, it's like 1 + 1 = 3. And it's the same thing when you run a midazolam infusion with a fentanyl infusion or an Ativan infusion with a fentanyl infusion. Like whenever you're combining those two different categories of drugs, they both make each other have stronger effects, and you could run lower doses of both, which is a really great thing.
And this is a unit specific breakdown in
patient population specific, physician specific, like what they're used to, what their training is.
Because oftentimes your physician team will be accustomed to, okay, for a patient with like agitation or a patient who you're trying to like lighten their sedation and move towards extubation, you end up in a place where you have a patient who still maybe has some pain control needs and maybe some agitation needs, only on Precedex. And then if they're only on Precedex, this is where you end up with the dex strip is at 1.5 mics per kg per minute.
And this is why they're braided. This is like
this
is a huge rate.
And they're still in pain. And then the nurse is like, dex doesn't work. It doesn't do anything because the patient's still likely in pain.
Yeah. Dex doesn't work because you're not controlling your patient's pain and they're having a lot of pain.
Right.
Dexmedetomidine is amazing for like helping someone just like, you know, if you have a patient who you're trying to wake up and get a breathing tube out of, especially if they've been intubated for like weeks and now we're just trying to get them to like, you know, we're not sure if they're gonna get a trach or not, or we're trying to like, you know, we're trying to vent liberate this patient and they're pretty much awake all the time. That's scary for them, right? We've all had the patient who's like sitting up in bed who is intubated and is like super chill, like reading a book, like watching
texting
like the Food Network and like texting. That's really cool, but that's a really special person to do that. It's scary to be in the ICU. A lot of times when people wake up in the ICU, they don't know where they are, they don't remember how they got there. Like
also being on the vent with positive pressure ventilation,
it's just uncomfortable, right? So like Dex is really great for a patient who's like been stable. They're not like necessarily in a lot of pain from surgery. They're not necessarily super swollen, but like we're trying to get them vent liberated. It's just enough to help the anxiety and to help the mild amounts of pain. Maybe they're getting Tylenol around the clock with it. Maybe they're getting like some PRN dilaudid or fentanyl here and there, like just to keep them comfy. Like that's awesome. Or alternatively, You know, if I bring up a big belly, an open belly patient to the SICU, like, okay, they had an X-lab, we closed the belly, they actually did great, like maybe they had a small bowel obstruction and we relieved the small bowel obstruction and now we close the belly and we expect this patient to do really, really well tonight. You can get the breathing tube out in like an hour or two. Totally. You know, the Dex would be a great infusion to bring them to the ICU on. It's just going to keep them comfy and bridge them over so that you can get the pain control on board, right? What I give in the operating room isn't going to last forever. It is going to wear off eventually. So you need to get your own pain control on board. And then that's going to bridge them to that extubation. So that's like another great opportunity. Dex is great for neuro patients because, you know, propofol is going to keep them sleepy. It has a context sensitive half-life. So like the longer the drip is on, the longer it takes for the propofol to wear off. So if you have propofol on for 5 minutes, it wears off pretty quick. If you have propofol on for 3 days, it takes hours to go away. So, you know, that's not great for a neuro patient who we're trying to get exams on frequently, right? So neuro patients, a Dex infusion with pain control is key.
Right.
But I think even a lot of providers are afraid to give the pain control because they're also confusing it with the sedative properties. They're so scared that if you give the fentanyl, you're going to make them too sleepy and it's going to mess up the exam. But in truth, if you're giving 25 micrograms of fentanyl at a time every 15 minutes and titrating it to effect, it's going to be a very safe way to give that medication. The peak respiratory depressant effects of fentanyl are at about the 5-minute mark. And in 15 minutes, you're already seeing like the full effects of the fentanyls, like pain control and like seeing if you really need more.
Which really gets into knowing the half-life of your medications.
Yeah, know the peak effect, know the half-life,
right.
Know the side effects, what to look out for.
Because again, like even with Propofol's pretty fast on, fast off if a patient hasn't been on for 12 days,
yeah,
or
12 days,
like 10 days, right? So if it's fast on, fast off, and then it's going to be largely out of the system within about like 5 minutes of cutting it off or reducing it significantly, then you don't need to, that's going to change your nursing interventions. You don't need to like wean your propofol for 4 hours for a single day surgery patient. Like, yeah, it can come off much faster than that. Same with Precedex, knowing how long it's on and off. Alternatively, like, and you can check out, I believe we might have the Milrinone. It's a lecture in the CCA membership. I don't know if we'll have it on the YouTube or not. But like knowing that the half-life of that is about like 4 to 5 hours, that's also key because you're going to know that it takes much longer to come on and off. So just knowing how your medications work and then using them in your benefit. A lot of times, even with fentanyl, I think sometimes nurses think that you can't give fentanyl because if they don't have like an advanced airway. And that's just, I was told this in the cardiac surgery ICU. One of the cardiac surgery ICU nurses who was like a pretty new grad told me that I couldn't give fentanyl unless they were intubated. I'm like, that's just not true. But
they do it in PACU every day. It's fine.
They do it in PACU
anyway. It's knowing. Don't get me started.
Know how your medications work and know how to dose them appropriately.
Yes, and again, you're gonna have orders for this, right? And then we also have Narcan available, and also your patient's on a monitor. Do not turn off your respiratory rate on your monitor alarm. Do not turn off your SpO2 alarms ever. If you need help troubleshooting, we have an entire lecture in the CCA membership about monitoring and how to troubleshoot your monitors. Yep. So, please troubleshoot correctly. So like if you have all those monitors in place and you're giving it according to the order set and like you're being cautious and you know what to look out for and you hold it if your patient's starting to look sleepy, like you're gonna be okay. One thing I want to add that's really important is sometimes I see the opposite problem. So instead of people under sedating patients, we have an issue where when people run fentanyl infusions, they also forget that it has that context sensitive half-life where the longer the fentanyl infusion's on board, the longer it's going to stick around, and they're like deeply sedating patients on high doses of fentanyl. And your patient is going to develop opioid tolerance really quickly. You're going to have all of those effects of like that constipation, like slowing down the GI tract. Like this is like the opposite problem,
which is not
right?
what you want for critical patients. For
yeah,
patients
they all already have GI motility issues. You're making it worse. And then you're also going to have the issue of like, now they have respiratory depression. Like, now they're like super sedated. Like a lot of times nurses will have orders for a propofol drip and a fentanyl drip. Like use that like synergy to kind of like get both of them in a really good sweet spot. So for example, one of our members works in a unit and this makes me so irritated that like everybody on the unit seems to be doing this, like a whole unit is doing this wrong. I'm like, Okay, so what they do is they're running the fentanyl at like 200 That's like really
It's
high.
really high.
And like, not that I've never done that before. I've definitely had patients with chronic pain who developed a tolerance.
You're also
and, like,
in the OR.
And they used to be like heroin users. No, like even in the ICU, right? Like they have really high opioid tolerances. And like this patient had a huge surgery and they used to do heroin beforehand. And like,
So
okay, I get why they need a lot of fentanyl to get comfy.
Of analgesia.
That's different. That's totally different. But when we're talking about like most patients, like running your drip that high and then they'll have the propofol at like 5.
Why?
5 mics per kilo per minute. You basically have no propofol on board. If you turned it off, your patient would look exactly the same. Why bother?
Well, then
so
that's understanding.
They're using the fentanyl at a really high dose to cause sedation instead of using the propofol for sedation and the fentanyl for pain control. So what that person could do is probably cut their fentanyl to like 50 and their propofol to like 50, and their patient would look great and have less hypotension, less like bad effects of the opioid. Again, they're not going to develop that like horrible tolerance to opioids, where now when we give them opioids after they're liberated from the vent, they're going to have like huge requirements because they've been on a massive fentanyl drip for days. Like you're causing a whole different downstream of effects in your patient. Ooh. So please understand, like if you're like this is why we have the scales.
Higher incidence of bowel obstruction, honestly.
I'm sure they do. I'm horrified of the whole thing. But you know, this is why we have the agitation scales, the Richmond,
the RAS,
the RAS scale. Was it Richmond agitation and sedation scale?
I think so.
Agitation, sedation scale, right? And then like that's why you're actually supposed to assess that every couple
like every
hours.
Hour.
Is it every hour? Oh, I don't remember. Okay, it's been a long time. But yeah, you like every time that you round on your patient, you should be seeing like how agitated they are. And then we also have a behavioral pain scale that you're supposed to do alongside that. So actually use the scales, actually think your way through it, and actually think like, is my patient having pain or are they having anxiety?
Is it a sedation problem or a pain problem? And they can need both sedation and pain control. And again, like the 50 mics of fentanyl an hour and the 50 mics of prop, that's also not like a prescription. But this is not
medical advice. Please
use your scales, and then 7-foot male young patient who has high opiate needs might need a little bit more than that, and a tiny little grandma might need less of both. So like use your clinical judgment for both, but then also use them together
and titrate them to your behavioral pain scale and to your Richmond and your RAS scale. Like you're titrating it to the scales,
exactly,
to their vital signs, to like your understanding of like what's going on with the patient. Mm-hmm. And then like again, like if you're running one drip at a really high dose and one drip at a really low dose, think to yourself like, does this make sense? Like propofol at 5 mics per kilo per minute, like what is that even doing? That's like a whip. If you calculate the mLs per hour, it's like 1 ml of propofol an hour.
It's like a sprinkle.
It's like a salt mist. It's like a mist of propofol over your patient. Like what are you even doing? And then like running your fentanyl at that crazy high dose, like opioids have consequences too. So like, could this patient get IV Tylenol? Or even down the OG tube, PO Tylenol or rectal Tylenol? Could they have that?
Yeah.
Could they also be getting like maybe some sort of a NSAID? That's like another option for some patients. I know in the ICU, a lot of our patients don't qualify for NSAIDs, but you know, who knows?
Use adjunctive therapy if their kidneys work, you know, but
okay.
Talk with your team.
Talk with the team. Come up with different options. And then again, if you're running your fentanyl drip at a really high dose, or your Ativan drip at a really high dose, or your midazolam drip at a really high dose, like maybe you need a second agent. Maybe that's the problem. If your dex isn't working, instead of running your dex at 1.5 and having the heart rate drop to 30, maybe you just need a PRN order for some Dilaudid here and there.
And speaking of using your PRNs, a lot of times, especially in the surgical patient population, you're given PO meds and IV meds. Mm-hmm. So if they're going to keep an OG tube in, they're going to be intubated for a day or two, use your PO medications. Like, especially if you can give PO Tylenol, PO Oxy, that's going to provide kind of longer acting pain control for patient than that really short on, short off fentanyl. And then you're able to give a little bit more like around the clock pain control in addition to your sedation.
Yeah.
And then as you're moving towards extubating, I always like to make sure that I give like the PO Tylenol and Oxy before like an hour before we pull the tube, so that hopefully that's on board.
Keeping awareness though, a lot of the times people suction out the OG tube like right before you extubate, which you should do. You should suction out your OG tube before you extubate. So like, want to think about that. Like, are you going to give the PO medication and then suck it out right away and then they're not really getting it? So like, make sure you think about like the timing of that.
Right.
Another option is like just a longer acting IV medication, like Dilaudid again. Like it really just depends, right? But so like planning ahead, critically thinking your way through it.
Also start low, right? So again, if you have a patient and they're not immediately presenting with very low or very high, like on either end of the spectrum, abnormal pain control needs, like you can always start with your Tylenol. You can start with your Tylenol, you can start with your lower dose and then see how they tolerate, especially if you're about to extubate, and then go from there. So like don't not treat pain because you're about to extubate, but do also, if you have a scale, a sliding scale, and you can either give like 5, 10, or 20 of oxy and you're about to extubate, don't give 20.
Don't give 20, yeah.
Start with the 5 or the 10
right.
plus the Tylenol and then go from there.
Yeah, because the breathing tube, and again, positive pressure ventilation is stimulating and uncomfortable in and of itself. So if you have a patient who doesn't really have signs and symptoms of like pain control needs and they're like a little sleepy and you think they're almost ready to extubate and you're kind of like maybe that patient doesn't need the oxy because maybe like you don't need to give them anything at all even because, or like whatever you want to do, because you don't want to make them any sleepier and then pull the tube, the only thing that's keeping them awake, and now they're out of it, right?
Right.
Conversely, if you have a patient who's breathing over the vent at a rate of 22 and they're awake and they're bucking and they're you can give them some pain control.
Yes.
Pretty safe.
Which again, fentanyl peak respiratory depression effects are like 15 minutes after. So if treat your patient's pain now, it'll probably take about 15 minutes for the RT to get in there anyway. And then see how they are, and then go from there. So like, don't not treat your patient's pain because you think you're about to extubate immediately.
Yeah, use your judgment again. If your patient's in a lot of pain, treat it. If your patient is like kind of sleepy, don't treat it, right? But so like I think these things like are really obvious to people who are more experienced, like duh. But when you're new and you're kind of like, wait, do I give it? Do I not give it? Like pause. Take a deep breath and think your way through the situation and look at the patient. Yeah, your assessment is all you have.
Assessment. And we're going to film an episode about assessment and how, like, as an ICU nurse or any nurse, like, really, the cornerstone of nursing is really, like, assessment and communication. So I'm excited about that episode as well. It's going to be good.
All right, gang. You're all amazing. Again, for, like, the in-depth farm stuff, please join us in the Confident Care Academy membership. We'd love to see you there. We have an amazing community of people who are reaching out to each other for questions and support. Their clinical questions, their ICU advice questions. We have, again, in-depth video lectures, a pharmacology library that grows every month.
Yeah.
We can't wait to see you there.
And comment what you would like for us to talk about on this channel next time. See you next time. Bye.
Bye.